I don't know if this is I don't know if this is the most interesting bacterium in the world or not, but it certainly makes a pretty good case for it. It's not a bug that we normally think about in terms of hospital epidemiology or hospital infection control. It's just not an issue in that regard, but it is one of the most common bacterial infections ever. And it really rocked the boat for us quite a bit. So let me take you back to the early days. This is what we used to think about the stomach, right? We didn't worry about microbiology of the stomach because the acidity was so high, 1 to 2%, 1 to 2 pH, really, really acidic. So that's where bacteria went to die. We would think about bugs like Salmonella, uh, Campylobacter, foodborne infections. The hard part for them was that just surviving passage through the stomach. Certainly nobody actually lived there. Um, and this is what we used to think about stomach ulcers, peptic ulcers. This is what caused it. Too much acid, too much spicy food, and too much stress. Those were the things that were the causes of peptic ulcers. Some of you remember those commercials. I have to realize this is back in the 70s now. Very few of you can go back and remember those commercials about, Alka-Seltzer and stuff. And it was all stress related. I like this quote right here. Pretty amazing. Ulcer in man is probably the classic example of a psychosomatic disease. It's all in your mind. It's all psychology. That's why you've got ulcers. So antacid, a bland diet, uh, stress reduction. That's how we went about treating stomach ulcers until these guys came along. This is Barry Marshall here on the left, and this is Robin Wright. Sorry, Robin Warren over here. He was actually the first guy to do biopsies of gastritis and stomach ulcers and see these little curved bacteria in there. They saw that in 1982. If those of you who are around in 1982 remember that we were all black and white back then, and we all had big mustaches like this. That was 1982. They published it 2 years later. Unidentified curved bacilli in the stomach of patients with gastritis and peptic ulceration. Looks like it's in the genus Campylobacter they mentioned there. And then, of course, famously, Barry Marshall just decided to show that this was really what was going on because people looked at this and said, "Oh, come on, no, 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 you're full of it." And so he actually took a culture of this organism and drank it and gave himself um, gastritis. And then a few weeks later became the first person to actually treat gastritis with antibiotics and recover from it. So pretty famous paper right there. They did get a Nobel Prize for all of that. They call this bug Campylobacter, which we think of course, as a gastrointestinal pathogen or an intestinal pathogen, really. It made perfectly good sense. This is Campylobacter on the left up here in the upper corner. And this is a really cool gram stain that we did here of Helicobacter in stomach. And you can see they look the same. They're these curvy, spiral shape almost gram-negative rods. They behave the same. They both are microaerobic or microaerophilic organisms. They're both rather finicky as far as when it comes to growth. So it made perfectly good sense. Anybody in their right mind would have seen this organism and called it Campylobacter. They called it Campylobacter pyloritis, pyloritis meaning of the pylorus, meaning it's this section of the stomach right down here is where you're going to see this organism and where you're going to get this gastritis and these ulcerations caused by this organism. And I'm sure probably every one of you is looking at this right now and saying that is an incorrect name. Of course it is. This is bad Latin. Everyone knows that pylorus is a second declension masculine noun, and the genitive form, this pyloritis, is third declension genitive. Completely wrong. And they recognized that very quickly and changed the name correctly to Campylobacter pylori. And then along comes some other researchers who did a lot of fatty acid analysis, a little bit of genetics. We really weren't that big into genetics back then. but they did some fatty acid analysis and showed that this bug is not closely related to Campylobacter at all. They may look alike, they may act alike, but they're really not very closely related. And so in 1989, it was renamed Helicobacter pylori. We now know that there are at least 54 different species of Helicobacter. Pylori is the one we worry about. It's the one that causes this disease in humans. Um, the others are in animals and do cause some occasional infections in humans, but not nearly as common as Helicobacter pylori is. So how does this bug do it? How does this bug survive and cause disease in a stomach that has so much acid? I will point out there's a lot about this bug. There's a lot about this bug. These are the major virulence factors that you can talk about. Motility and chemotaxis. It's chemotactic for the stomach wall. As soon as it gets dumped into the stomach, it starts swimming directly for the wall. There's something in the stomach lining that attracts this organism and it swims over up to it. Then it's got these adherence factors that can reach out and bind to receptors on the surface of gastric epithelial cells. That's going to keep it from getting washed away. Otherwise, as you churn your food and pass it on through, it's going to move right along with it. But no, it sticks to it. Very importantly, it produces a lot of the enzyme urease. Urease is going to take urea, which is going to be found naturally in the stomach, and breaks it down, converts it into bicarbonate and ammonium ions. And that's going to push the pH up. That's going to neutralize all those stomach acids. So you can see here that out in the lumen of the gastric, of the stomach, where the pH is like 1 to 2, right here where Helicobacter is going to be living, he can raise the pH up to about 6 or so. So he's living in the stomach, but he's not living in that acid that we think of being in the lumen of the stomach. And some other things. This is a cytotoxicity associated gene, which kind of turns on pro-inflammatory genes, human pro-inflammatory genes, causes inflammation, and vacuolating toxin, which just punches holes in the gastric epithelial cells to cause injury there, which is going to lead to more inflammation. All of that leads to this chronic stomach inflammation, this chronic gastritis that this bug can produce. There's a lot more to it. This is really, I say, one of the most interesting bugs in the world. This is really one of the more complicated bugs in the world. This is the only bug that I can think of right now that has his own journal. I mean, this whole journal is dedicated to nothing but the virulence and the epidemiology of Helicobacter. And it started in 1996, only 14 years after they first saw this in tissue specimens. This bug grew to have his own journal. So there is a ton of stuff out there. And what I'm going through here today is really the bare bones of this organism. You could spend in months talking about this bug. So gastritis, peptic ulcers, and then the next straw was the causation of gastric cancers. It takes a long time. This is decades that this goes, but it goes to this chronic gastritis caused by Helicobacter, which progresses through to various forms of metaplasia, dysplasia, and eventually into stomach cancers. Helicobacter being, I hate to say the cause. It's not the cause. There's several things that go together, but this is a cofactor in the development of stomach cancer. And it is clearly the most important cofactor in the development of stomach cancer. 90% of all stomach adenocarcinomas are directly attributed to Helicobacter pylori infection. If you could wipe Helicobacter pylori off the face of this earth, then you would almost totally wipe out stomach cancer. Almost totally. It is the only bacterium that is officially listed as a class 1 carcinogen known to cause cancer. There are a few viruses, there's a couple parasites, but Helicobacter pylori is the only bacterium that is considered to be a carcinogen. 37% of all cancers that come from chronic infection are by Helicobacter pylori. There are some other ones. He's the number one, but there are things like schistosoma causing bladder cancer, hepatitis causing liver cancer. So there are some other possibilities there. But as far as chronic infection leading to cancer, Helicobacter is your number one. I threw this in here just because it's kind of cool. The papers that I read weren't really able to definitively say this. They didn't want to say it, but possibly also a cofactor in the development of rectal and colon cancer. On the other hand, if you completely wiped out Helicobacter, you might actually see more esophageal cancer because it seems to be protective against esophageal cancer. So there's a lot of stuff going on. And the cool thing about this, from a microbiology perspective, is this is a bacterium. We can look at things like human papillomavirus and say, yeah, I see how that causes cancer. But a bacterium leading to cancer is just a really weird thing to think about. Real quick on his epidemiology, adults higher than children. I'll tell you why in just a second. Geography matters. Here's the geography of Helicobacter. You can see where the hotspots are: Russia, Brazil, whatever that place is. What is this place right here? I don't know. All the Kazakhstans and Azerbaijans, those places. Pakistan's, certain spots in Europe, in Africa, even though there's a lot of Africa that does not have any data available on right now. United States is this light pink color, less than 40%. But you look at that and say, oh, that's low. Less than 40% of the population is currently infected with Helicobacter. That doesn't seem that low when you think about it. The percentage in the United States is actually right about 30%. But that's current prevalence of Helicobacter infection. Higher in rural areas, higher in lower socioeconomic and poor hygiene. The global prevalence has come down pretty dramatically, and this may well be due to the fact that we can now treat Helicobacter infection and eradicate Helicobacter infection from infected people. Fecal oral routes, you're going to consume the organism. Here's the cool thing. 90% of all cases are acquired during childhood. During childhood is when you get this. Most of the people who are infected, it's going to stay colonizing their gut for their entire life. All of them will develop some form of gastritis, although in 80% of them, it's going to be asymptomatic gastritis. And about 10, 11% of those are going to go on to peptic ulcer disease. I don't have any stats on how many of them are going to go on to gastric cancer at this point, but it is a childhood infection that manifests itself, if it's going to manifest itself at all, is probably going to be during adulthood. I will say a word about treatment, and I don't want to go into the treatment is really rather complicated. If you look up the guides, there's like 7 or 8 possible regimens that they recommend. But the cool thing about it is that you're treating gastritis and peptic ulcers with antibiotics, completely different from what we thought back 40 years ago. So things have completely changed there. That's the main point I wanted to make there. And it does depend somewhat on the macrolide resistance rate that you get. We'll come back to that in a bit, because how are you going to know what your macrolide resistance rate is to decide on one of these 2 treatments? All right, I'm a microbiology, I'm a lab person, so let's talk about diagnosis. We'll go through all of these individually here, but you can see they're divided up into non-invasive methods and invasive methods. Invasive methods are going to mean you're going to have to go in there, you're going to have to get a stomach biopsy in order to do it. Non-invasive methods means we don't need to go in and get a stomach biopsy. So let's talk about serology on the first part. For the decades, this is what we did. This was the only test we had available to look for Helicobacter. Did you have antibodies against Helicobacter pylori? What's good about it? We draw a blood specimen, easy to do. What's good about it is that there are CLIA-waived versions. It could be done point of care, like these right here, simple little tests. You put the blood in the little cartridge and watch for the line to show up showing that you have antibodies. But here's what's bad about it. IgG lasts a long time. IgG is really going to last pretty much your whole life if you have this chronic infection. But there's a lot of people out there who are seropositive. And so what they found is that a positive IgG really didn't mean a whole lot. Uh, it meant that you were infected or had been infected at some point. It does not mean that you have active disease going on at this point right now. Problem with all serology, you cannot differentiate, or it's difficult to differentiate past infection versus active infection. And you cannot use it to monitor therapy. That IgG level is going to be up there. You're going to have IgG for a very, very long time. So I can't use it to see whether we're successfully eradicating the organism. Like I said, for years, it was number one. It was the only way that you could diagnose Helicobacter. But now we do not perform it. It's been taken, I should say, it's been taken off the market. That's not exactly true. You can still buy kits like this, but all the good, reputable reference laboratories have completely dropped serology testing. They don't offer it anymore. Here, we offered it here, but it's gone away. We do not offer it anymore. So don't do serology. Histopathology is going in and looking at a biopsy. So this does require an endoscopist to go in there, stick a tube down your throat, into your stomach, and I'm going to put this mildly, rip out a piece of your stomach wall to take a look at it under the scope. See, I just have a little bit of an issue there with a disease that causes peptic ulcers. Is it a good idea to go and intentionally rip out a piece of your stomach wall? But that's what we do, and we do it quite a bit. So this is an H&E stain, and a good pathologist can look at this and tell you that there's a lot of inflammation going on here. This is a sign here of gastritis. I am not a good pathologist, but they can also get a little closer and look in there and see the actual little curved bacilli. So there's the next sign, a nice little curved rods associated with that gastric mucosa. And then even a little bit better, do immunostaining. So this brownish precipitate here shows you that it is reacting with antibodies against Helicobacter pylori. So you can get rather specific with it. What's good about it is you actually see the disease. You actually can tell what's going on. You can see the organism clearly. This is active infection if you can see it in there. If there's other possibilities, though, you can look and see that there's evidence of other diagnoses besides Helicobacter as well. So this is really considered the gold standard for diagnosis. Do a stomach biopsy, take a look at it under the microscope. What's bad about it? Like I said, it's invasive. You got to go in there and pull out that piece of the stomach wall in order to do it. You might miss the spot. The infection is not diffuse. It's kind of spotty. And so it's possible you could biopsy a site that's not affected by it. That's an issue. Theoretically, there are some other non-pathogenic curved gram-negative rods that might be in there. That has been seen before. But if you immunostain, then you can take care of that situation as well. You will know that it is Helicobacter. Plus, I wanted to use the word ameliorated. I don't use the word ameliorated enough. So I like that word. Here's another test that's commonly done. We do this test here. This is the CLO test. CLO, believe it or not, stands for Campylobacter-like organism. So this test has been around for a long time. It is looking for urease production. Remember, the bug produces a lot of urease. So you take out that piece of stomach wall and you smush it down underneath this gel here. If it produces urease, it's going to raise the pH and change the pH indicator from yellow to pink. So you smush it in there, you let that incubate. We usually read it at about 4 hours and then let it go overnight for 24 hours. And if it turns pink, that's positive for urease production. And the presumption is if there's strong urease production in that stomach biopsy, it's got to be Helicobacter. So it is good evidence of active infection. We final negative at 24 hours, but a positive typically comes up faster than that. Good sensitivity, good specificity, and it is CLIA waived. Still, you have to have a biopsy. Still, you might miss the site, or you might have a particularly low bacterial load where you happen to be. Sorry. Specificity may be affected by other urease producing organisms. Believe it or not, there have been people who have been colonized with Proteus in their stomach that have caused positive results here. And here's a big thing for a lot of these tests here. Sensitivity will be decreased if you have had recent use of proton pump inhibitors, bismuth salts, or antibiotics. That will decrease the sensitivity. So the recommendation is before you have this test, you go for 2 weeks without taking any of those. That could be a problem for somebody that you suspect has Helicobacter infection. But we'll come back to that again. This is another cool one. This is one that when I first heard about this decades ago, I said, this is ridiculous. This will never work. But it works really well. We use C13 non-radioactive carbon now, but you have a pill that has urea in it made with C13 heavy carbon. You swallow the pill, goes into the stomach. If there's Helicobacter in there, it's going to produce the urease that's going to break down that urea. The ammonium we don't care about, but the bicarbonate, this heavy C13 labeled bicarbonate gets into the bloodstream, it goes to the lungs, and then you will breathe it out as C13 labeled CO2. So a patient comes in, patient swallows the pill, you wait 15 to 30 minutes or so, and then you'll blow out into this little bag here. This is a before bag. This is before you take the pill, and this is an after bag. And you put them into an instrument like this, it's going to measure the C13 that's in those two. And if you have a lot of C13 in your breath after taking the pill and not much before you take the pill, that's evidence of Helicobacter. It's evidence of urease in your stomach. It works. It's non-invasive. You don't need a biopsy. And I don't care if it's spotty or not in your gut because we're sampling the entire stomach here. Evidence of active infection, very good sensitivity and specificity. It's FDA cleared for adult patients. And it's rapid unless you have to send those bags out. Sometimes some labs, you have to send the bags out to be analyzed somewhere else. So it may take a few days to get those results back. It does take this kind of specialized setup with the pill and the blowing in the bags and stuff, and processing is not particularly easy. There can be other urease producing organisms there. It's not FDA cleared for children. And the same issue, you want to go for a couple of weeks without taking these medications before you do the urea breath test. So it's a really, really cool test. It's really kind of weird the way it's done, but it works very well, works very well. Then there's this test. This is the test that we offer here. We do it here at Micro. A stool antigen test. Just test a stool specimen to see if you have Helicobacter antigens in those stool specimens. This is the actual one that we use. You have this little prep here. We put a little swab of poop in this little prep device, drop it in the cartridge. It's a fluorescent read, so it goes in this instrument to read. It takes 15 minutes. So it is very rapid. Active infection, easy specimen collection. All you got to do is poop. Okay. Very high sensitivity, very high specificity. It's the cheapest of all these tests, any age. And we can use it to monitor therapy. So after you go on therapy, we can take another poop specimen in a couple of weeks and see how much is still there and do it again and see if it's still there. So we can kind of monitor to see when you become negative for the antigen test. Same issue. Sensitivity may be decreased if you've taken any of these. So you want to go 2 weeks without taking any of these before you do this test. And believe it or not, there's the ick factor. Patients are often hesitant to provide a stool specimen. That actually is a real issue. I don't know about you, but if you ask me, do you want to poop in a cup or do you want to get a piece of your stomach ripped out from this biopsy? I'd poop for you. I would, I promise. So it's a quick, easy, rapid, cheap, relatively cheap test. And it's really, really good. High sensitivity and specificity for detecting active Helicobacter infection. Okay, let's talk culture. We can culture. We can do this. I mean, the culture's got these great things. Obviously, if you culture the bug, you've got active infection. Obviously, if you culture the bug, that's 100% specificity. The bug is there. And you get a bug that you could do susceptibility testing on. If you've been treated once, twice, and have failed treatment, then we can have the bug to do susceptibility. But this is a really, really finicky bug, a very hard bug to grow. Stomach biopsy, keep the specimen cold. That specimen got to come out of that patient's stomach, go on ice. Stay on ice until it gets to the laboratory. It needs to get to the laboratory as fast as possible. I have actually, believe it or not, I've actually stood in the endoscopy suites and watched them do stomach biopsies. I mean, within 30 seconds, it's out and in the ice, and then I drive it straight to the laboratory. Set up the plates immediately, high CO2, humid environment. We let it go for 7 days before we call it negative. You can see how tiny these colonies are. Sometimes even its stomach, even in stomach, you're going to have to subculture to get rid of some other organisms as well. Very easily overgrown by other organisms. It's a hard, hard bug to grow. We've been fairly successful at getting it to grow. But once you've got it growing, then you want to do susceptibility testing. We don't do that. Very few hospital laboratories are going to have the media or procedures needed to do it. Sending it to a reference laboratory is a problem because it's got to live. You know, our primary reference laboratory is in Utah. I mean, planes take it there. They get it there, you know, within 12 hours. But it's usually dead by the time it gets there. I figure only about 20% of the time do we actually get susceptibility results back because the bug has usually died on the way. So we are searching for a better way to do this. How about PCR? Is PCR a better way to do things? Of course, you know, we've talked about so many times where culture is being replaced by PCR because PCR has such big advantages. It should work. It should have high sensitivity, high specificity. Presumably, if you get DNA, that's going to be indicative of a active infection, and you don't have to worry about trying to grow the bug. Here's the problems. There are no FDA cleared methods. I cannot purchase a kit to do PCR. No commercially available methods at all. It's going to have to be a complete homebrew, which is going to take a long, long time for us to create that. And reference laboratories have very limited availability. There's only one reference laboratory I know of that does the test. One of the other problems with Helicobacter is there's a lot of genetic diversity in Helicobacter. So coming up with a set of primers and probes that are going to cover the great majority of all of your Helicobacter pylori strains is difficult to do. I'm going to do some advertising here for Mayo Clinic. Mayo Clinic is the only lab that I know that actually offers a PCR for it. And you can do it on tissue, do it on that stomach biopsy, or you can do it on feces, which I think sounds great. Not only that, but they are capable of detecting a clarithromycin resistance, a few mutations that lead to clarithromycin resistance. And remember, clarithromycin was in one of those treatment regimens, one of the main antibiotics that's used. So this is great. This is fantastic. And we can try it sometime. We have not utilized it to this point. So overall, here are your diagnostic approaches. And this is based on the latest guidelines from the gastroenterology group. Patients who have epigastric pain, weight loss, iron deficiency, anemia, dyspepsia, these are considered the warning signs, the alarm features, or anybody who's over 60, their recommendation is that you do invasive testing, that you do a stomach biopsy and get the histopathology. You can look at it and see it and tell what it is you've got, or any other diseases that might be associated with that gastric mucosa, and do a rapid urease test as well. That's the recommendation. If you're less than 60 and don't have any of these features right here, then they recommend non-invasive testing, the stool antigen or the urea breath test. And you can continue to use those to monitor treatment. And you even in the people on the top there, you can use those tests to monitor treatment as well. Repeated treatment failures. If there's more than 2 times that you've been treated and you still have Helicobacter, then biopsy and try to culture and try to get susceptibility testing done. So the cool thing about Helicobacter is not just that it's a stomach bug and that it does gastritis and peptic ulcers and cancer. That's all very cool. Completely changed the way we look at those kind of things, but also that there are so many options for diagnosis. I mean, I don't know of any bug where we have 3 or 4 different tests that are specifically designed to look for this one organism. So that's kind of unusual as well. Now, to finish it up here, let me say, this seems prime candidate for a good vaccine. I mean, and thinking back to, we're used to the idea now with human papillomavirus of using a vaccine to prevent cases of cancer. So we can do the same thing here. If we can vaccinate all kids, because that's when they're going to be getting the infection, is when they're children, vaccinate them, we can almost wipe out stomach cancer. That's just a pretty cool thing to think about. This is just a recent paper from a couple months ago. There is a vaccine that has passed. I think they misspelled that. Phase 3 clinical trial, a recombinant subunit vaccine against the urease enzyme. Good prophylactic effects. So things are moving in that direction. There are some candidate vaccines, and I would not be surprised at all within the next 5 years or so that Helicobacter vaccine comes on the market, and we can again get in this idea of vaccinating children to prevent cancers later on down the road. So a really cool bug. One that we try to deal with from a microbiology perspective. It's very difficult for us. We do cultures here occasionally, but the stool antigen test and the CLO test and the urine breath test give us lots of options on dealing with this organism. And that's what I've got on Helicobacter. If anybody has any issues, questions, I'll be happy to give them a shot.
Anybody have any questions? It's always fascinating to me the pathogens and that can cause cancer. It's worrisome that you can get something when you're a child and it can impact you long term. So.
Yeah, and that's one of the cool things about it, is because I'm old now, so I'm thinking back when I was in college. There was no question, cancer was not an infectious thing at all. We didn't know about human papillomavirus. We knew about things like schistosoma hematobium occasionally leading to bladder cancer. But as far as a bug being such a strong cofactor as to actually be called this is the cause of the disease, that's something that's pretty new in the world.
Yeah.
And having a vaccine to be able to take, I mean, we've learned from human papillomavirus, but be able to say, yeah, you can have a vaccine that's going to prevent you from getting stomach cancer. Now, stomach cancer rates in the United States are not particularly high. It's not one of our top 3 or 4 cancers, but in other parts of the world, it is.
Right.
So it'd be interesting to see.
Yeah, very, very interesting. Any questions from the group?
Dr. Junkins, if I may.
Sure.
I had the opportunity to work in the endoscopy department for a time, for about a year, and we did a lot of these EGDs with biopsy of the stomach for testing for H. pylori, and they would take the specimen from the antrum of the stomach.
Yes.
And that was very specific. If they were biopsying the antrum, they were testing for H. pylori. Do you know, is there any particular reason why the antrum and not just a random sampling?
No, that is where it almost always hits, is right down in that part. I am completely unknowledgeable about exactly why it does that. I'm assuming that it has to do with adherence to the epithelial cells. It's the same kind of thing when you get into the intestine. There are intestinal cells in certain parts of the intestine are expressing different receptors. So it may just be that the adhesins that Helicobacter produces recognize receptors that are found in that portion of the stomach.
This was
I'm
very
kind.
interesting. Thank you so much for your answer.
Oh, you're
Appreciate it.
welcome.
Any other questions? All right. Well, thank you very much. And hope everyone has a wonderful day.